Hello, everyone. My name is Sarah Niemi de Paiva, and today I will be presenting the results of the KIKOP project and its impact on infant mortality in Kisii County, Kenya. Let me just share my screen. I would like to acknowledge the KIKOP community health volunteers, as well as Barbara Mufaletto, the Impact Global Health Alliance Program Manager, and Ann Karubo, the project coordinator. This report was also made possible through the collaboration of KIKOP and the community and international partners. We are deeply thankful for the contributions of each partner whose insights and dedication were key in shaping this report. KIKOP is a community-based organization that functions within community and governmental networks to drive, mobilize, and facilitate efforts aimed at improving maternal and child health. The success outlined in this presentation reflects the collective effort of all parties. The impact described here is a testament to the teamwork and shared commitment of all involved. We look forward to further strengthening these partnerships to continue advancing maternal and child health outcomes in the coming years. Here I have a few abbreviations that I might use throughout the presentation. The important ones are KIKOP, which is the Kisii-Kanya Oriboro project, and maternal mortality rate, which is MMR. First, let's talk about KIKOP. Before we get started, KIKOP was launched in 2018, and the partners are Impact Global Health Alliance and the Kisii County Department of Health. This program covers 3 different catchments: Iranda, Matongo, and Nyagato. The key strategies of this intervention are holding care groups intended for new mothers, routine home visits, youth empowerment, and strengthening health systems in Kisii County, Kenya. Here I pasted from the website KIKOP's main interventions, which include number 1, mobilizing communities, community health extension workers, village health committees, community health volunteers to work in partnership with the local health facilities. Number 2, adapting existing level 2 and level 3 health facilities in the project to the community birthing center model. Number 3 is training and incorporation of traditional birth attendants to encourage facility-based deliveries and referral. Number 4 is utilizing village-based volunteers and mother peer educators to disseminate health messages using the care group approach. Number 5 is utilizing a census-based monitoring and evaluation approach, utilizing Impact Global Health Alliance's community-based impact-oriented methodology. And number 6 is to empower community partners to create an obstetric emergency response system. And lastly, number 7 is to ensure that women receive respectful, culturally appropriate, and equitable services during maternal care. The methods that KIKOP utilizes is a community-based, impact-oriented approach to address the most critical health issues in partnered communities. Family health data is collected through routine health home visitation, the review of health records, surveys, and group meetings. In this way, our work can be modified to meet the evolving needs to the community. KIKOP conducts a census every year to track progress, and this is conducted by enumerators with community health volunteers as village guides. The data is captured using the Meaningful app system on tablets. enumerators go from household to household and speak with the household heads to gather information for the census. The survey focus areas are household demographics, including migration status, residency duration, respondent role, and consent. They also collect information on pregnancy and live births that happened in the previous year, including child names, birth dates, and birth locations. We also record mothers' engagement with CHVs and participation in neighborhood group meetings. Tracking of live births, stillbirths, miscarriages, and deaths with detailed information such as name, age, gender, relationship, and pregnancy and postpartum status. Additionally, for deaths that were reported, verbal autopsies are conducted for deaths of children under 5 years of age and women aged 15 through 49. Let's discuss the results of the 2024 census. First, let's look at community health volunteer visits. Among the 362 birthing parents that reported live births in 2024, only 9 out of those 362, or 2%, did not receive visits from a community health volunteer to check on the mother and child's health and well-being. Similarly, for mother support groups, of the 362 birthing parents that reported a live birth in 2024, only 23 out of the 362, or 6%, did not participate in the twice monthly neighbor group meetings with other mothers in the community. So we can see from this data that people participate in these support groups, and they also accept visits from health volunteers. Now let's look at the mortality rates that we calculated from information from the census. For perinatal mortality rate, this is calculated by adding stillbirths and early neonatal deaths, and then dividing by total births and multiplying by 1,000. And this was calculated as 5.3 per 1,000 births for the perinatal mortality rate. Similarly, for the neonatal mortality rate, neonatal deaths are divided by live births and multiplied by 1,000, and we calculated 2.7 per 1,000 live births for the neonatal mortality rate. For infant mortality rate, this is calculated by adding neonatal deaths and post-neonatal deaths, dividing by live births and multiplying by 1,000. And this was calculated as 13.3 per 1,000 live births. Here I've pasted a chart that shows progress with infant mortality from 2018 until 2025. We can see that the first year, infant mortality was at 94.7 per 1,000 births, and this has been slowly decreasing up until 2024, when 0 deaths were reported, and now in 2025, we calculated 13.3. So this has decreased significantly and then increased again slightly. Now to move on to the under 5 mortality rate in Kissee County. This is calculated by adding infant deaths and child deaths and dividing by live births and multiplying by 1,000. This was calculated as 16 per 1,000 live births. We also calculated maternal mortality, which is calculated by dividing maternal deaths by all live births and multiplying by 100,000. And for this, we calculated 533.3 maternal deaths per 100,000 live births. Again, I've pasted the data from previous years here. We can see that in 2018, the maternal mortality rate in the KIKOP catchments was quite high at 1,515 maternal deaths per 100,000 live births. And we saw decreases each year until 2021, and then a small decrease again, and then a small increase this previous year. Lastly, we have miscarriage rate, which is calculated by dividing the amount of miscarriages by total births plus miscarriages and multiplying by 1,000. And this was calculated as 10.52 per 1,000 pregnancies. Let's compare these results with the World Health Organization recommendations. So for infant mortality rate, we observed the value of 13.3 infant deaths per 1,000 live births. And this is unfortunately not below the WHO target of less than 12 infant deaths per 1,000 live births. But fortunately, it is quite close. Next, for maternal mortality rate, we recorded 533.3 maternal deaths per 100,000 live births, and this remains significantly higher than the World Health Organization Sustainable Development Goal target of less than 70 per 100,000 live births. Next, for neonatal mortality rate, we recorded 2.7 per 1,000 live births, and this is now below the World Health Organization target of less than 10 per 1,000 live births, reflecting positive progress in neonatal survival. Let's compare these statistics in Kisii County with the rest of Kenya. So we recorded the 533.3 per 100,000 live births for maternal mortality rate in Kisii County. And this is lower than Kenya's national figure of 594 per 100,000, indicating success with the program here in Kisii County. Next, the under 5 mortality rate of 16 per 1,000 live births in Kisii County is significantly lower than Kenya's national figure of 34.8 per 1,000 live births in 2024, demonstrating a notable improvement in child survival in Kisii County. Let's move on to the causes of death that were recorded in the deaths that were identified through the vital events census. Of the 5 deaths recorded, pneumonia was the cause of 2 of them. And both of the cases involved premature infants, including a triplet. 1 death was due to a feeding accident where the infant choked on breast milk during a nighttime feeding. Another death was due to malaria, but this was misattributed to witchcraft by the family. Another death was from epilepsy and seizures. A 3-year-old experienced prolonged convulsions leading to death. And another death was due to prematurity when a newborn was born at 28 weeks gestation due to low birth weight and prematurity complications. Next, to go over the delays in seeking care. The failure to recognize danger signs, or the type 1 delay, had 5 cases where this was applicable, where caregivers missed critical symptoms such as respiratory distress, seizures, and choking risks. And Next, the delay in seeking medical services, or type 2 delays, had 4 cases where this was applicable, where cultural beliefs and myths such as witchcraft or over-reliance on traditional medicine led to the death of a child. Third, delay in accessing skilled care, which is the type 3 delay. 3 cases where this was applicable, where transportation and financial barriers prevented parents from seeking medical care. Fourth, delays in receiving quality care, or type 4 delays, where 4 cases were applicable. The health system gaps, like lack of equipment, emergency drugs, or staff shortages, led to these deaths. In conclusion, KIKOP's success in Kissee County is evident in the reduction of infant mortality rates and the neonatal mortality rates, demonstrating the power of community-driven interventions in improving child health outcomes. And the positive trends in maternal and child health outcomes reflects the project's focus on education, regular health visits, and the empowerment of local communities. However, these findings also highlight the persistent challenges in maternal health, particularly the high maternal mortality ratio. This suggests the need for continued efforts to improve maternal health care access. And here are my references. Thank you very much.